Dear students, as you can see on the screen, our topic today is first lecture on inflammation. It includes nomenclature, general characteristic, and more details about acute inflammation. Let's start with definition. Inflammation is a complex vascular mesenchymal reaction in response to injury or pathogenic stimulus. Inflammation manifested in reactions aim to remove and eliminate of damaged products and repair within the zone of injury. There are some clinical features of inflammation. You know, in Latin, it is color, rubor, tumor, dolor, and funcellesa. Dolor means pain, as released chemicals stimulate the nerve endings in the inflamed area. The area is painful to touch. Color means heat. The warmth is due to increased blood flow to the area. Rubor means redness. The inflamed area looks red as the capillaries in the area are filled with more blood. Then tumor, swelling. The fluid buildup causes swelling. And funcellesa means loss of function. There might be some loss of function as a result of lack of use due to pain. Here you see the picture of injury, tissue injury, you see in the finger, followed by inflammatory reactions. You see rubor, color, tumor, dolor, and of course, loss of function. There are various causes of inflammation. Physical agents like heat, cold, radiation, mechanical injury. Also chemical agents like organic and inorganic poisons. Infective agents like bacteria, viruses, parasites. Immunological agents, cell-mediated and antigen-antibody reactions. Inflammation is distinct from infection. Inflammation is a protective response by the body to a variety of etiological agents, both infectious or non-infectious, while infection is invasion into the body by harmful microbes and their resultant ill effect by toxins. Inflammation involves two basic processes with some overlapping. So early inflammatory response and later followed by healing. Though both these processes generally have a protective role against injurious agent, inflammation and healing may cause considerable harm to the body, as well as, for example, an anaphylaxis to bites of insects or reptiles, drugs, toxin, atherosclerosis, chronic rheumatoid arthritis, fibrous bands, and adhesions in intestinal obstruction. Immunity or immune reaction and inflammatory response by the host are both protective mechanisms in the body. Inflammation is the visible response to an immune reaction, and activation of immune response is almost essential before inflammatory response appears. Depending upon the defense capacity of the host and duration of response inflammation can be classified as acute inflammation and chronic. So here you see the scheme, types of inflammation divided into acute one and chronic. Acute inflammatory response by the host to any agent is a continuous process, starting from injury, then goes vascular events and cellular events. They are very important. Intimately linked to these processes is the release of mediators of acute inflammation. You must know that acute inflammation is of short duration, lasting less than 2 weeks, and represents the early body reaction, resolves quickly, and is usually followed by healing. The main features of acute inflammation are accumulation of fluid and plasma at the affected site, intravascular activation of platelets, polymorphic nuclear neutrophils as inflammatory cells. You must remember that these cells are the main cells in inflammatory infiltrate, polymorphonuclear neutrophils. Please remember that is very important that there are three phases of inflammation. The first one, alteration, other words, is injury. You have already studied cell injury, and you know that injury presented with dystrophy and necrosis. This is the first step, alteration, the initial stage. Then goes exudation, and the last one is proliferation. Here you see the picture with stages in inflammatory reaction. Tissue injury, for example, injury by pin. Here you see the skin surface, epidermis, and after the tissue injury we have release of chemical signals such, for example, like histamine, and you see then coming reaction. The second goes dilation and increased leakiness of local blood vessels. We see migration of phagocytes to the area. We see the swelling in the area of injury. And here you see the increased vascular permeability, and we see the phagocytes and fluid move into the area of the injury. Then phagocytes, including macrophages, neutrophils, consume bacteria and cell debris, and with time we see the healing reaction. Tissue heals. So bacterial products, immune complexes, toxin, physical injury may result in the tissue damage. Then macrophage and other cell activation and mediators on inflammation, which stimulate the inflammatory reactions. So in acute phase reaction, we see fever, the patient looks sleepy, loss of appetite. We see acute phase proteins, various hemodynamic disorders, even shock in severe cases, of immune reaction, for example, and neutrophilia. Of course, mediators of inflammation results in various endothelial reaction. We see the increased leukocyte adherence, then increased synthesis of PGI, increased procoagulant activity, and also decreased anticoagulant activity, increased interleukin 1, 8, 6, and PDGF. All this reaction also very important to vascular disorders mechanism. Then with time we see the starting of repair or regeneration reaction of healing. And in that stage we see the fibroblast effect, the increased proliferation of cells, connective tissue cells like fibroblasts, increased collagen synthesis, increased collagenase and protease and PGA synthesis. And also we see leukocytes effects in cytokine secretion like interleukin 1 and 6. So again, with more details about all these stages. Alteration, the first stage, alteration is a cell injury, degeneration or dystrophy and necrosis of the cell tissue, which is accompanied by mediators released by plasma cells, for example. Then goes exudation, and we see at that phase the formation of exudate. We see a microvessels reaction with disturbance of blood rheology. Then goes increased vascular permeability, and starting with exudation of main blood components, emigration of blood cells, phagocytosis, then formation of exudate, and at the end development of inflammatory reaction, inflammatory infiltration. The third stage is the stage of healing or repair, starting repair stage, cellular proliferation. We see variable cellular proliferation in different types of inflammatory reaction. There is no significant cellular proliferation in acute bacterial infections, except in typhoid fever, in which there is intestinal lymphoid hyperplasia. Viral infections have the ability to stimulate cellular proliferation, for example, epidermal cell proliferations in Hermes simplex, chickenpox, and smallpox. In glomerulonephritis, there is proliferation of glomerular capsular epithelial cells resulting in formation of so-called crescents. In chronic inflammation, we'll study chronic inflammation a bit later, but in chronic inflammation, cellular proliferation of macrophages, fibroblasts, and endothelial cells occurs. Few more words about chemical mediators of inflammation, endothelial cells, epithelial cell. You see here cellular mediators, preformed mediators in secretory granules like histamine, serotonin, lysosomal enzymes. They're released by mast cells, basophils, platelets, neutrophils, macrophages, So serotonin, platelets, lysosomal enzymes, neutrophils, and macrophages. And also during inflammation, we see newly synthesized like prostaglandins in all leukocytes, platelets, endothelial cells, leukotrienes also in leukocytes and endothelial cells, activated oxygen species in leukocytes, nitric oxide in macrophages, and various cytokines in lymphocytes, macrophages, and endothelial cells. From liver, which is the main source of various plasma factors, Factor 12, Hageman factor activation, also stimulates kinin system, for example, bradykinin. Then coagulation fibrinolysis system, and also goes complement activation, various C3A, C5A, C3B, C5b9, various complement components which may cause anaphylaxis or membrane attack complexes. The same picture, which helps us to understand the major effect of interleukin 1 and TNF, or tissue necrosis factor, in inflammation. These mediators stimulate endothelial effect, which cause vascular permeability and all vascular disturbances, followed by further development of inflammatory reactions. Here you see the blood vessels and increased permeability for fluid and proteins, also cells like monocytes, neutrophils, and the maturation of monocytes resulted in macrophages formation, neutrophils after apoptosis in case of inflammatory reactions were phagocytes by macrophages, and then growth factors released, which stimulate new blood vessels formation and stimulation of fibroblasts growth and cell division. And at the end, these cell proliferations result in repair of tissues. So the role of macrophages is very important because of phagocytosis of dead cells via apoptosis and cell debris as a result of tissue necrosis. According to predominant one of the phases, inflammation is classified into two big groups: exudative inflammation and proliferative. Depending on the defense capacity of the host and duration of response, as we have already known, inflammation can be classified as acute and chronic. The type of tissue reaction to injury could be different, like normal, hypo reaction, and hyper reaction. Also, according to etiology, we divide inflammation into specific type and non-specific type. Acute inflammation, exudative inflammation, divided into few groups depending on the type of exudate. First one is serous inflammation, then goes pseudomembranous inflammation, catarrhal inflammation, fibrinous inflammation with two subtypes, Croupo's inflammation and diphtheric one. Then purulent or separative inflammation, hemorrhagic, and mixed. Let's start with serous inflammation. Characterized by effusion from blood, non-viscous serous fluid, commonly produced by mesothelial cells of serous membranes, but may be derived from blood plasma. The skin blister, for example, resulting from a burn or viral infections, represents a large accumulation of serous fluid, either within or intermediately beneath the epidermis of the skin. Serous exudate contain until 2 protein and less quantity cells like neutrophils, macrophages, and desquamated epithelium. Serous inflammation localized usually at serous membranes, and we see the symptoms of polyserosities, for example, at rheumatic diseases, uremia. We see this kind of inflammation in mucus, like in serous rhinitis. We can see in skin, in case of streptococcus infections, herpes, and burn. Seldom this kind of inflammation revealed in internal organs, for example, serous pneumonia. The outcome or fate of serous inflammation often favorable for the patient. Here you see the picture, the finger of the patient with the serous inflammation. Under microscope, we see the accumulation of serous exudate and the epidermis, and so we see sort of swelling in this area and also the redness of the skin of the finger as a characteristic picture of serous inflammation of the finger skin. Again, the same pathology, serous inflammation, low power view of the cross section of the skin blister showing that epidermis is separated from the dermis by the focal collection of serous effusion here you see. Now we go to other kind of exudate inflammation, catarrhal inflammation. This kind of inflammation is accompanied with increased secretion of clear mucus or mucin. The catarrhal inflammation may be serous, separative, and mixed one. An inflammatory process that occurs in mucous membranes and is characterized by increased blood flow to the mucous vessels. Also, we see edema of the interstitial tissue, enlargement of the secretory epithelial cells, and also profuse discharge of mucus and epithelial debris revealed in case of catarrhal inflammation. Here you see the example of catarrhal inflammation in stomach. The folds of the mucous membrane of the stomach swollen, covered with a large number of viscous cloudy exudate. The mucous membrane is congested and there are some tiny petechial hemorrhages. Here you see the acute colitis. This had a rapid onset. It quickly led to death from dehydration. This is a girl, 9 years old. No causative organism was found. The colonic mucosa is thickened and bright red color due to inflammation. Now we go to fibrinous inflammation or pseudomembranous inflammation. In various books they are mentioned under these names, which are synonyms. So this kind of inflammation has two subtypes. The first one is Krupp's inflammation, and the second is diphtheric one. Fibrinous inflammation or pseudomembranous inflammation. This kind of inflammation resulting in a large increase in vascular permeability, which allows the blood vessel to pass through fibrin. A thin, adherent, grade-wide exudative layer composed of necrotic epithelium and debris, fibrin, bacteria, and neutrophils, which is both atop and merges with the underlying mucosa. This kind of inflammation caused by Streptococcus, Pneumococcus, immune complex, Shigella, Corynebacterium diphtheria, and other pathogens. It is localized in mucous and serous membranes. Here you see the gross photo showing a total colectomy specimen with plaque-like adhesion of fibrinopurulent necrotic debris and mucus to damaged colonic mucosa. Usually Krupp's inflammation, as you know now, it is subtype of fibrinous inflammation, the Krupp's one. It develops on the columnar epithelium. Fibrinous membranes peel off easily without any effort. And the other subtype, like diphtheric fibrinous inflammation, develops on the squamous or intermediate epithelium. And fibrinous membranes peel off with some difficulties. And as a result, we see some tissue injury in this area. This gross specimen is an example of fibrinous pericarditis. So we see the gross specimen of the heart with pericardium, and as you see in the picture, the epicardium is dull, covered with grayish-yellow rough overlays in the form of filaments resembling the hairline. Fibrin filaments are easily detached. In some books you can read the description like the hairy heart, so it means like these membranes, like filaments, they resemble the hair of the human. Histologically, fibrin appears as an eosinophilic network of threads. This exudate may be removed by fibrinolysis and other debris by macrophages. This process called resolution may restore normal tissue structure in the area of this fibrinous inflammation. But sometimes we see replacement of such exudate by connective tissue, and it is called organization. Afibrinous exudate may accumulate in cavities such as the pericardium and pleura. And here you see the fibrinous pericarditis. F means fibrin. Pink meshwork of fibrin exudate overlies the pericardium surface. Here you see under letter P the pericardium surface with this overlies fibrin exudate accumulations. Here you see the microscopic picture of the tissue sample of the lung of patient with Croup pneumonia. And you see here few alveoli divided by interalveolar septi, and all alveoli are filled with exudate containing fibrin filaments and polymorphonuclear leukocytes. Here you see a lot of leukocytes and tiny meshwork of fibrin, pinkish color of such fibrin within the alveoli. Croup pneumonia, staining for fibrin according to Shuveninov. Here you see such special staining of alveola. This is a very high magnification of the microspecimen. Fibrin filaments are purple. In places they penetrate through the pores in the alveolar walls from one alveola to another. Here you see such example. The other picture is diphtheric inflammation. You know now that it is the second subtype of fibrinous inflammation. Here you see the exudate rich with fibrin, visible portion of the mucosa and underlying tissue necrosis of tonsils filled with fibrin and polymorphonuclear leukocytes. Here you see such exudate. On the periphery of the fibrinous film there is a demarcation zone with dilated congested vessels and an accumulation. Here you see the accumulation of polymorphonuclear leukocytes. The fate of such inflammation, one of the fate is organization. Organization of fibrinous exudate within the pericardial sac lead either to fibrous thickening of the pericardium and epicardium in the area of sedation, or more often to the development of fibrous strands that breach the pericardial space, and we call such process as obliteration. Suppurative inflammation marked by pus formation and could be diagnosed in various processes like abscess, phlegmon, empyema, furuncle, carbuncle, and cellulitis. These all processes are example of suppurative inflammation. Here you see subcutaneous bacterial abscess with collection of pus. You see here the pus, greenish yellowish mass under the skin. Here you see the skin. Under the skin you see the tissue infiltration by pars. So this is an example of separative inflammation. If we take a piece of tissue, process it, stain it, and study under the microscope, we see the picture like here. A lot of cells, a lot of neutrophils, then the area of tissue necrosis infiltrated by neutrophil, the edema fluid, cellular debris. All this is within the abscess in case of separative inflammation. Here you see the kidney, the whole kidney sample, and we see the big abscess and also the small ones, a lot of multiple abscesses. Here you see the big one, another big one abscess. So here you see the example of embolic embolic abscesses, and on the surface we see various foci, big and small ones, grayish yellowish coloring, which have inside the area the accumulation of pus. Under microscope, these abscesses look like these foci, oval foci of inflammation, separative inflammation, rich with neutrophils, and here dark bluish centers are the accumulations of the microbes. So when here you see the embolic purulent nephritis, this is a kidney tissue. When examining under a magnifying glass or low magnification of the microscope, we see multiple foci of purulent inflammation, abscesses, which are visible in the cortex and the medulla, the kidney tissue in the foci of purulent fusion. In their center there are small vessels, the lumens of which are obturated with microbial emboli. Here you see the liver sample, liver abscesses. This material is from the autopsy of the female patient, 87 years old. This patient died from gram-negative septicemia, and the abscesses are complication of this. And the site of the original infection was not found. We understand that it could be various primary cause, like caries of tooth, for example, and then in case of low immunity we can get the septicemia and various abscesses in organs, and various organs, including liver, like here in this picture. Acute peritonitis associated with appendicitis. So this is a dissection of a female body, 18 months old. Peritonitis complicates appendicitis. more frequently in children than in adults, because in adults the greater momentum is more likely to seal off and acutely inflamed appendix. The thin greenish pus can be seen in the lower skin flap. Here you see. The next picture is a cerebral abscess in right hemisphere. We see the brain of male patient, 9 years old. The abscess has been presented for some time, as indicated by the presence of the partial capsule. Recent extension has occurred in 2 places, here and the second one, through the tiny capsule of the abscess. Again, acute peritonitis resulting from a small perforation in the sacrum. Newborn child with neonatal necrotizing enterocolitis, and as a complication we have an acute peritonitis. So please note the dilated bowel with dull red serosal surface on which there is a fibrinous exudate. Tiny filaments, tiny fibrinous exudate, different from the normal one. The appendix is dilated, its serosal surface is reddened and covered by a fibrinopurulent exudate. Here you see the yellowish areas of suppurative inflammation, and so in some areas whitish cover of the serosa. Here you see the gross specimens of brain in case of acute meningitis. There are focal collections of pus in the subarachnoid space. This is the usual postmortem appearance of meningitis. Haemophilus influenza was cultured from this patient before the death. Another picture of neonatal meningitis. Male patient, 4 days of pathology. The meninges are reddened from the vascular congestion. Thick greenish pus fills the subarachnoid space. Most cases of neonatal meningitis are due to coliform organism, as this one was. The leptomeninges over the frontal lobes have been torn and the surface of the brain is visible. Osteomyelitis, female patient, 21 years old. There is a large collection of pus in the medullary cavity of the shaft of the femur. This patient died from acute leukemia, and the infection resulted from her immune deficiency state. So this is one of the cause, the immune deficiency. One of the cause stimulated the suppurative inflammation of the bones, and we see here the cross-section of the bone in medullary cavity of the femur, and the diagnosis of osteomyelitis was made. Now here you see hemorrhagic inflammation, the example of hemorrhagic inflammation. Pericardium, pericardial sac, you see dark brownish reddish exudate. The pericardium is opened and reflected to reveal a pericarditis that has not only fibrin strands, here you see tiny whitish strands, here they are, strands of fibrin, but also a lot of hemorrhages. Thus, this is termed as hemorrhagic pericarditis. It is really just fibrinous pericarditis with hemorrhage. Without inflammation, blood in the pericardium sac would be called hemopericardium. But this is the result of more severe inflammation or vascular injury. So when we see hemorrhagic inflammation, it means that it is quite severe inflammation, quite severe vascular injury by bacterial toxin, for example. And it can happen in various severe pathologies. Here you see the acute hemorrhagic pancreatitis, which was the cause of death of the patient. Here you see the area of necrosis, we see the hemorrhages, and yellowish spots of enzymatic fat necrosis. Here you see the complex of uterus, ovaries, tubes. So bilateral piercings. The female, 49 years old. We see the fallopian tubes, which are dilated and their serosal surface reddened. Here you see the brain and changes in meninges, meningitis, and a result of this inflammation, we see some dural collection of serous sanguineous fluid. So it is possible complication of meningitis in a patient, female patient, 2 years old. Here we see the histological picture of the lung tissue of the patient with bacterial pneumonia. Under microscope we see that alveolar exudate, here one alveolar, the other one, the third one. So alveolar are filled with exudate, which composed mainly of neutrophils. The surrounding alveolar walls have capillaries that are congested. They are dilated and filled with erythrocytes. Such an exudative process is typical for bacterial infection. This exudate gives rise to the productive cough with purulent yellow sputum seen with bacterial pneumonias quite often. The alveolar structure is still maintained here in this picture we see. That is why even extensive pneumonia often resolves with minimum residual destruction or damage to lung parenchyma. However, in patients with compromised lung function from underlying obstructive or restricted lung disease or cardiac disease, even limited pneumonia consolidation can be life-threatening. For example, similar pathology quite often was seen in severe cases of COVID-19 infection, with also when bacterial infection is added to viral infection of COVID-19. There are various systemic effects of acute inflammation. Fever occurs due to bacteremia. It is thought to be mediated through release of various factors like prostaglandins, interleukin-1, tumor necrosis factor in response to infection. Leukocytosis commonly accompanies the acute inflammatory reactions. In the range of 15,000 to 20,000 cells in milliliter, then the counts are higher than this with shift to left of myeloid cells. The blood picture is described as leukemoid reaction. Usually in bacterial infections there is neutrophilia. In viral infections, we see lymphocytosis, and in parasitic infections, commonly eosinophilia seen. Typhoid fever is an example of acute inflammation, however, induces leukopenia with relative lymphocytosis. Also, as a systemic effect of acute inflammation, we see lymphadenitis, which is one of the important manifestations of localized inflammatory injury. The lymphatics and lymph nodes that drain the inflamed tissue show reactive inflammatory changes in the form of lymphangitis and lymphadenitis. This response represents either a non-specific reaction to mediators released from inflamed tissue or is an immunologic response to a foreign antigen. The affected lymph nodes may show hyperplasia of lymphoid follicles, like follicular hyperplasia, and proliferation of mononuclear phagocytic cells in the sinuses of lymph nodes, like sinus histiocytosis. Then systemic effect of acute inflammation could be such severe reaction as shock. So shock may occur in very severe cases. Massive release of cytokine like tumor necrosis factor, which is the mediator of inflammation, in response to severe tissue injury or infection. It also result of severe infection. This may be caused by profuse systemic vasodilatation, increased vascular permeability, and intravascular volume loss. The net effect of these changes is hypotension and shock. Systemic activation of coagulation pathway may occur, leading to microthrombi throughout the body and resulted in disseminated intravascular coagulation, bleeding, and death. Such reaction, you must remember, could be seen also in case of COVID-19 infection. You know that during pandemic, in our hospitals we had many autopsies of the patient died from the complication of this severe infection, and the blood circulator disorders, then various changes in vascular increased permeability, vasodilatation, various microthrombi through the body, disseminated intravascular coagulation are also seen in such patients, and a lot, for example, of hemorrhages, petechial and focal hemorrhages in lungs and other organs were revealed. So, as a result of acute inflammation, there are various processes, like the first one is resolution, which means complete return to normal tissue following acute inflammation. This occurs when tissue changes are slight and the cellular changes are reversible, so resolution may happen in lobar pneumonia. So this is the best outcome of the acute inflammation, resolution, and full repair of the tissue with such pathology. Next go the healing, but healing not with restoration or repair by the same tissue, but the healing by fibrosis. And it happens when the tissue destruction in acute inflammation quite extensive, and there is no tissue regeneration or repair due to that. But when tissue loss is superficial, so not such severe, this tissue may be restored by regeneration or full repair of the original tissue. Next example is suppuration. When the pyogenic bacteria causing acute inflammation result in severe tissue necrosis, the process progresses to suppuration. So, for example, such inflammation could be also after even viral infections and other pathogenic stimuli. So we see intense neutrophilic infiltration in tissues, subsequently mixture of neutrophils, bacteria, fragments of necrotic tissue, cell debris, and fibrin comprise pus, which is contained in cavity to form an abscess. The abscess is not drained, may get organized by dense fibrous tissue, and in time get calcified. You know, this is sort of dystrophic calcification, as you know, which could be a result of the calcification of fibrous tissue in the area of previous acute inflammation. And also you must know the acute inflammation may result in further inflammatory process, prolonged inflammatory reaction, and as a result, we see the features of chronic inflammation. So, persisting or recurrent acute inflammation may progress to chronic inflammation, in which the processes inflammation and healing proceed side by side. So, next lecture will be devoted to chronic inflammation and various types of chronic inflammation, which is one of the kinds of chronic inflammation, could be result of the recurrent acute inflammatory reactions.